Good morning. My name is Dave Walker. I'm co-chair of this committee along with Dr. Phil Pizzo, who's here today as well. Welcome to Stanford Medical School. I now have to read the obligatory IOM public meeting statement, so please bear with me. As co-chair of this study, along with Dr. Phil Pizzo and of this committee meeting, I would like to welcome everyone to this public session. The task being undertaken by this committee for the Institute of Medicine, of the National Academies, is to examine the current state of end-of-life care and to explore approaches to advance the field. The committee's statement of task is indicated on the information sheet that has been handed out for this meeting. In addition, I want to note that this is an open, on-the-record session. Interested individuals and members of the press have been invited to attend as observers. This is not a news conference. However, we will not be entertaining questions from the floor. Reporters who would like to talk with members of the committee are kindly asked to contact the National Academy's Office of News and Public Information. I would also like to remind everyone that this is an information gathering session. That is, the committee is in the process of assembling materials that we will examine and discuss in the course of making our findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee is just beginning its work. As a result, we have not made any findings or drawn any conclusions, and it would be a mistake for anyone to leave here today thinking otherwise. In fact, this is just our second meeting. Comments made by individuals, including the co-chairs and other members of the committee, should not be interpreted as positions of the committee or of the Institute of Medicine. In addition, committee members typically ask probing questions in these information gathering sessions, which may or may not be indicative of their personal views and may or may not be indicative of the views of others on the committee. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and the committee then must respond to this review with appropriate revisions that adequately satisfy the National Academy's extensive report review committee procedures before it is considered a National Academy's report. Now with that out of the way, I'm pleased to welcome our first presenter this morning, Lynn Christiansen, Senior Strategic Policy Advisor for Independent Living and Long-Term Care with the AARP Public Policy Institute. And I want to thank her on behalf of the committee for flying all the way out here to be with us today. She's going to be leaving to go back to the East Coast this afternoon. So, Lynn, the floor is yours.
Thank you very much. Thank you. Good morning, everyone. It is truly an honor for me to be with you today. I know a number of the committee members who I've had long-term relationships with as someone who's worked in the field of aging for so long. So, again, it is a privilege for me to be here with you today to talk about an issue near and dear to my heart, which is families who are caring for loved ones at the end of life, but also for those that are caring earlier on with people who might have chronic conditions or disabilities. So this morning, I've been asked to talk about three things, and I'm going to give an overview of family caregiving very briefly to lay out who family caregivers are, what they do. I'll then talk about what policies we have currently to recognize and support families in their caregiving role, and then talk about what policies that we need, particularly at the end of life. What I won't be talking about today are public policy issues related to advance directives, because this is a group that is very familiar with those policies and efforts to discuss better communication among family caregivers and professionals. What I'm going to be focusing on today is an area that is less likely to be talked about in public policy circles, which is for many family members who are in the workforce, juggling caregiving and work issues. There really has not been a lot of attention to their needs, particularly at the end of life and at bereavement. So I'll be focusing in on that. And lastly, I just want to say that some of the policy needs that I'm going to bring out are my views and views of caregiving advocates in the field, and not necessarily views of AARP. So with that, I will begin, and just very briefly, most of you are aware that when we talk about family caregiving, we have a broad definition, really any relative, partner, or friend or neighbor who has a significant relationship with and who provides a broad range of assistance for an older adult or an adult with a chronic or disabling condition. The average U.S. caregiver is a 49-year-old woman who works and spends nearly 20 hours a week in addition to her job, caring for her mother unpaid for nearly 5 years. Now, most family caregivers don't identify themselves with the word family caregiving. That's really more the professional term. Really, most family members think of what they do in relationship to caring for their loved one, be it a wife, a niece, a husband, a daughter, a son-in-law, a close friend. We know that about 1 in 5 adults in this country are family caregivers. More than 8 in 10 are caring for a relative or friend age 50 and over. Most are female, typically wife or adult daughter. But the trend is for men taking on the family caregiving role. 46% of family and close friends who are caregivers perform medical nursing tasks as well as help with personal tasks such as activities of daily living or instrumental activities of daily living like managing bills, paying bills, doing transportation, and whatnot. And 61% of families in the caregiving role do work outside the home in addition to their care role. And about 3 out of 4 family members have been in the workforce while they are juggling caregiving. So this translates into about 42 million family caregivers in the United States who provide about 40 billion hours of care to an adult in 2009. Another adult or an older adult, that is someone age 18 and over. The estimated economic value of these families' contributions was about $450 billion in 2009, up from $375 billion in 2007. So imagine, if you will, if our families and friends went on strike for a day and said, I'm not going to do this anymore, what that would do to our health and our long-term care system and our society. So these are the individuals, all of ourselves in this room and across the country, who need better recognition and support. Now, these slides show family caregiving in the old days, and we know that historically, caring for an ill family member or friend was largely ignored and rarely in the public light. It was really an expected role of women in the privacy of their own home and in their community, and typically short-term, because most people didn't live till old age. People died of acute rather than the chronic or multiple chronic conditions that we have today. The average lifespan in this picture, which was around the turn of the last century, around 1900, was 47 years of age. Today, life expectancy is about 78 years and projected to go to 80 years in 2020. So this is what we call and what we know as the new normal of family caregiving, increasing diversity, smaller family size. So what is different about caregiving today than in the past? Well, there is a longer duration of caregiving because of multiple chronic conditions and also increased life expectancy, which makes caring for the older population a longer part of the lifespan. There's greater complexity of the family caregiving role, both as care coordinators and service providers. And I like to say that families are not only taking on the role of nurses without being prepared for their role, but they're also taking on the role of social workers. I can say that because I am a social worker, where they are navigating an incredibly difficult and fragmented healthcare and long-term services and support system, which is one of the biggest stressors for families as they take on this caregiving role in the beginning, when a diagnosis is made, to the end of life, and even after. And families are also today providing complex care and doing medical tasks in the home, as I said, and more women are in the workplace. Nearly half are in the workplace today, up from 33% in 1960. And we have changing compositions of families and households, more long-distance caregiving. In that slide I showed earlier of the family at the turn of the last century, most everyone in that household was probably living together or living on the same street or living in the same neighborhood. We don't have that today. We go back and forth with very geographically dispersed families, increasing diversity, high rates of divorce. The divorce rate of the 50-plus population has doubled between 1990 and 2010. So who will be taking care of whom? We also have fewer adult children, which means smaller families, which translates into less sibling support to share the care. And the percent of frail elders, that is people 85 and over without any surviving children, is projected to increase from 16% in 2000 to about 21% in 2040. And increasing numbers of childless women. These are some statistics that not everyone is aware of. Nearly 20% of women are childless today, compared to 10% in 1970. So the future of family caregiving looks very different than in the past. What are the costs of caregiving? We know that family caregiving comes at substantial cost to the caregivers themselves. There is a large and well-established 30-year body of literature that shows that not only is caregiving meaningful, gives purpose to someone's life, but also comes at great risk to the families themselves. Family caregivers are a vulnerable and an at-risk population that really our healthcare and long-term care systems simply neglect. There are physical health risks, emotional strain and mental health problems. Depression is very pervasive, particularly for someone caring for a loved one with dementia. An estimated 40 to 70% of dementia caregivers suffer clinical symptoms of depression. There is social isolation, especially at end of life, financial burdens, workplace issues that we'll talk about, and retirement insecurity. And caring for a loved one with chronic conditions or disabilities is now viewed as a public health concern. So the policy context. We know that serious illness or disability affects the family as well as the person. Yet in public policy, most all of our policies are beneficiary focused, not looking at the wider frame of how people live their life. Most people with serious chronic illness cannot manage on their own, and they rely on their family, broadly defined, could be a close friend or a partner. And these family caregivers are the invisible workforce in healthcare and long-term services and supports. Again, the lack of recognition, the lack of respect for the work that families do, the lack of training to help prepare families to do what they're doing today in the modern world, and again, the focus on the beneficiary in payment and service delivery, rather than addressing the notion of person and family-centered care. So the paradox is that the policy direction toward more home and community-based services and away from nursing home care, which is what most Americans value and want, depends greatly on family caregivers. Yet we don't properly recognize them, support them, and prepare them for their caregiving roles, which comes at great emotional cost. So now I'm going to move on to 5 public policies that we do have in the United States that currently do recognize and support family caregivers. Of course, Medicare's hospice benefit, which addresses the patient and the family's needs, where the unit of care is the family, not just the patient, which is very important as you deliberate and move forward in developing new policies at the end of life. There's also the Family Medical Leave Act that was signed into law by President Clinton in 1993 that guarantees up to 12 weeks of job-protected but unpaid leave for a worker's own health or for certain family care, including at the end of life, but only if you're caring for a child, a spouse, or a parent, and we'll come back to that in a few minutes. And then there's the Older Americans Act and the National Family Caregiver Support Program, also signed into law by President Clinton in 2000, which really transformed the aging network, the network of services and supports for older adults across the country. Because for the first time in social policy, the family caregiver became the client in this public system of supports for older adults. And it is funded very modestly at $155 million, but it does provide caregiver support services across the country, largely through area agencies on aging, including vital family counseling sessions, support groups, training, and respite care to give families a break. And it's funded at, as I said, about $155 million, very modestly. And then we have the Lifespan Respite Act that expands and enhances respite services in the states, but the funding level is just a drop in the bucket at $2.5 million. And then last, but certainly not least, we have to mention the Affordable Care Act, which does mention the term caregiver 46 times and the family caregiver 11 times. I had a graduate student that actually read the entire Affordable Care Act. And we do know that the Affordable Care Act does promote new models of care, but the opportunities exist to elevate families and to provide better support, but to date, this has not been done very systematically. So that's what we have. So I'm going to propose actually 9 ideas. I wanted to do 10, but I actually like 9 better than 10. The end ones are going to be dealing with, again, the needs of people who are in the workforce who are also family caregivers, because this, again, is an area where you may not have given a lot of thought in this particular committee to the public policy issues that are so important to families in the modern world. But the first, and in my view, one of the most important, is to conduct an Institute of Medicine study on family caregiving. It really is time to develop a national strategy and actions that government and communities can take to raise and elevate the needs of family caregivers from private issues into public concerns. And the Institute of Medicine is the entity to do this in a very powerful and meaningful way. Second is to assure that federal health care and long-term services and support programs implement person and family-centered assessment and support protocols as a condition of receiving federal, state, and state funds. This idea comes from 2 caregiving advocates and policy analysts in Washington, D.C., Carol O'Shaughnessy at the National Health Policy Forum and Carol Levine at the United Hospital Fund of New York. Thinking about, as we move forward with patient-centered medical homes, all the community-based care transition programs, in Medicaid, the home and community-based services waivers that allow more funding for home care and community support, and for the CMS Innovation Center demonstrations to ensure that one needs to talk to the family member if they're involved in the person's care plan and provide support services appropriately. And third is to modify reimbursement in Medicare and Medicaid so that health and social service providers have identify, assess, and communicate with family caregivers, and that this is rewarded. So what this can mean is to identify family caregivers in electronic health records, not only at end of life, but in the beginning of the caregiving journey, that can also allow tracking of the family caregiver's change in health over time, and to encourage primary care providers and other healthcare professionals to routinely identify Medicare beneficiaries as part of Medicare's annual wellness visit. It's now public policy to, if you're a Medicare beneficiary, for primary care providers to assess for depression and assess for dementia, but to not ask that Medicare beneficiary, are you caring for another family member or friend? How are you? And what help might you need? These are changes that are not huge, but can make a huge difference in the public health of our nation. Fourth is to increase and preserve funding for the National Family Caregiver Support Program, which is so vital to many family caregivers across the country. and particularly the respite services that are essential throughout the caregiving career as well as at end of life. And fifth is to incorporate end of life and support for families in care transitions policy and practice as an essential element of quality of care. For me, it's noticeably absent in discussions of care transitions, the words end of life. Probably the most important care transitions, most important care transition, but very typically, when we talk about care transitions from hospital to home, from home to nursing home, we rarely mention end of life and support for families. And this should be part routinely of all care transitions policy and practice. And now for 6 through 9, I'm going to focus on the needs of working caregivers because most family members who are caring at the end of life for a loved one or even before are typically in the workforce, and they need legal protections to allow them to do their work and also provide the vital and meaningful care that they want to do and that their loved one wants them to do. So one is to increase the reach of the Federal Family and Medical Leave Act to expand the relationships covered by the law to include domestic partners, parents-in-law, grandparents, and siblings. Imagine if you're at work and you get the call and you need to go care for your in-law. You are not protected under federal law. That's crazy. Or for many of us as we age after our parents die, our next big caregiving journey will be our siblings, something we rarely talk about. And yet under federal law, under the Family and Medical Leave Act, you're not allowed to take unpaid leave to care for a sibling. These things need to be changed, as well as domestic partners. We need to require employers to protect workers in businesses with fewer than 50 employees. Most women work in small businesses. They're not covered under the Federal Family and Medical Leave Act. And also to cover bereavement leave. Employees shouldn't be afraid of losing their jobs when they're dealing with the death in the family. But the Family and Medical Leave Act only says caring for another certain family member, a child, a parent, or a spouse, when the person is still alive, but maybe at the end of life, but not bereavement leave. Seventh is to adopt policies at the state level that exceed the current federal eligibility limit for the FMLA. Again, current state laws don't address bereavement, although many businesses do have a bereavement leave policy, but not all of them. So again, this session today is focusing on caregiving and family issues. We know that at end of life, the person dies, but the family lives on. So these issues, bereavement policy, are critically important. A bill just passed in the Oregon legislature that would give up to 2 weeks off to grieve the death of a family member. This bill came about because the representative, a woman, Representative Fagan, introduced the bill because before she had been elected to their state legislature, she had been in the private sector. Her father had died, and she traveled to Dallas to grieve and to plan the memorial service. She stayed there for 2 weeks to take care of business and to mourn. And when she came back, she was fired from her job. So she introduced a bill to change that. We allow employees unpaid time off to care for certain ailing family members, but there is no job protection if they don't show up for work the day after the family member dies. We also need to promote access to paid leave. Again, the Family and Medical Leave Act is unpaid leave. California and New Jersey lead the way in 2 states that do allow paid leave, because for most workers, when they're caring for somebody at the end of life, it's a real financial hardship to take time away and not get paid during that time. And ninth, we need to adopt policies at the state and local level to prohibit discrimination of workers with caregiving responsibilities, including requirements to provide reasonable accommodation for working caregivers. So what does this mean? This is a whole emerging area of law called family responsibilities discrimination. And I'm going to give you some real-life examples based on real cases in the Center for Work-Life Law database from the University of California, Hastings College of Law, just a few miles from here. An employee is fired when he asks for leave to care for his seriously chronically ill family member, for his father. An employee, these are real cases, an employee is denied leave when her employer asserts that it is not her responsibility to take care of her ailing mother as long as her father is still alive. Think about that. An employee is called lazy and then fired after taking leave to care for his mother, who is near death. And then a factory worker, Jonathan Bell, was laid off after taking several days of FMLA leave to care for his father, who was in a coma and eventually died. His supervisor yelled at Bell for taking time off, called him lackadaisical, and later fired him. The employer maintained that the time off that Bell took was not care for his father, because his father didn't even know he was present, and no medical decisions need to be made. So as you deliberate on these important issues of end of life, I hope that you will also consider these workplace policies that really do not get enough attention in the modern world for all of us that are struggling for work and caregiving. And so I will close with a quote from Jonathan Roush, who is at the Brookings Institution, who wrote a prolific article in The Atlantic called Letting Go of My Father. And he was talking about family caregiving, and I'll quote, and he said, "What we need is for our nameless problem to be plucked out of the realm of the personal and brought into public view where help can find us." So I thank you very much. Yes, absolutely. Yes.
Again, the questions are only from the committee members, but if any of the committee members have any questions of Lynn, please proceed.
Yes.
Thank you. That was wonderful, Jean Cutler. So you mentioned at the beginning that family caregivers don't identify themselves as caregivers, which is probably an issue for both describing and reaching the group as well as research in that area. So what other terms do people use to identify themselves? Because you're trying to find out what the burden of caregiving is. If you use a term that people don't self-identify, they may not describe it.
That's right, absolutely. So the question is, if people don't self-identify as family caregivers, what terms do we use? Typically in a lot of social service programs, when people are doing outreach, they talk about, are you caring for another family member or friend? You can get as specific as, are you caring for your husband, your son, daughter, whatever. Increasingly, the word caregiver is becoming more common, but oftentimes it's confused with healthcare providers or direct care workers, but we like to use caring for another family member or friend. Yes. Hi, Naomi.
Hi, I have a question. So now, pursuant to federal law, we have a national Alzheimer's plan, and I know obviously people with dementia are just one population of care recipients, but I'm wondering if there are things, if you know whether there are things in the National Alzheimer's Plan that address any of the policy recommendations that you've made today.
I think there are some for the support services and for better care transitions and whatnot, but not necessarily on the employment protections.
Lynn,
yes.
Phil Pizzo, that was a wonderful presentation. Thank you. I have two questions that are not connected. First of all, what happens to those individuals who don't have families? What are the potential outcomes for them? And the second is, what are the remedies for addressing the employer problem? Because since we are a nation of so many small employers, aside from legislation, how would we be able to execute a change?
right? Two very important questions. Some people don't have family, but they may have close friends. And the options at the end of life are probably different for people that don't have that close family or friend support. As for small businesses, there sometimes is pushback to have more mandates. But yet, my experience is I talk to employers, and increasingly more in my work, I'm really focused on the needs of families that are also in the workforce and trying to balance this. There is an understanding that even in small companies where there may be 5 or 6 employees, people will really pitch in and share if one person has to be out because a sister may be dying. So I think with workplace flexibility and other areas, we can, in fact, continue to encourage people to be workers, but also providing care as well. And I think there's actually less reluctance over time. There have been many studies of the Family and Medical Leave Act, as well as the paid leave programs in California and New Jersey, that show that the burden on employers is really minimal.
Thank you very much, Lynn Christiansen. I noticed in your definition of family caregiver, you said caring for an older person or adult. I was wondering, being the ARP, are you partnering with any groups that advocate for caregivers of pediatric or younger people?
Yes, we definitely advocate intergenerational and with children's issues, but I was specifically focusing this particular talk on caring for adults. But very good point, thank you.
As well for the talk, Pat Bomba. I had a question. Can you elaborate a little bit on the paid leave and recommendations for the duration of the paid leave, or what the experience is in California and New Jersey?
The experience in California, well, I can only speak to California, where I used to live here. I lived here for 33 years and did work on getting enacted the paid leave law in California, which was a coalition between children's advocates, work-family advocates, and aging advocates, where you can take up to 6 weeks and get paid leave, partial paid work replacement. And it comes out of the employee's check, not the employer's responsibility. That's something that many people don't know. So there are different ways to craft that so the burden is not on the employer. It's not full wage replacement. It's about 66% of your wages.
Thank you.
So when you were describing the demographics, Lynn, you spoke about the fact that individuals are marrying later or partners connecting later, having children later. On a global basis, of course, there are policies and changes around the world, particularly in Asia, China, Japan, where family size is rather small. What are the implications for that as you look forward in terms of family support?
Good question. I think that the implications are that we have to prepare for a future where we can't just depend on our informal care system to provide the support that we need when somebody has chronic conditions or at the end of life. So we're going to have to really critically and planfully plan for the fact that there are going to be fewer family members to provide care for a burgeoning older population.
Well, just given the amount of money that's already being expended, not expended, but that is not being reimbursed for the care being given by families, what does that mean, or what do you think are the potential remedies for that?
Maybe we can shift some funding.
From where to where?
Well, as I had in some of my recommendations, to really think about changing some payment reform in both Medicare and Medicaid that would provide better recognition and support for families, so that even though there may be fewer family members in the future, Those that will be available will still provide care for their loved ones, but they will need better support to be able to do that, and probably for longer periods of time.
Right. But to be a bit provocative, given the fact that the Affordable Care Act is reducing some of the outpatient services, given the fact that the entitlement programs, including Medicare, is under tremendous pressure right now, what do you envision, or what do you think is going to be the resources to enable that to happen?
I think that it's just changing the way the resources are allocated and how we pay for and deliver services, so that we're not just focusing on, so that we're focusing not just on the person, but the whole family unit as the unit of care. And that's what we need to think about, and shifting some resources from more specialized treatment to maybe what we call some of the softer services, which may be training a family member of how to do wound care in the home, because many families are doing that now, or they're asked to prepare special diets, but they don't have the information and the resources to know how to do that. When we don't do that and we rely on the family to provide these medical nursing tasks in the home, what happens is, if the family member doesn't know how to do it, there's a higher likelihood of hospital readmissions. But if we had actually prepared that family member and provided adequate support up front, we could possibly reduce costs down the road and improve quality of care and quality of life.
Do any other committee members have questions?
Thank you. Carla Holloway, Duke University.
Hi.
Thank you for your presentation. It's very thorough and provocative as well. And I'm wondering, to what degree do you believe that Title VII or ADA might be able to incorporate some of these disparities that you spoke about? Mm-hmm. And on the other hand, to the extent in which we want to legalize these remedies, how do you think about the word family as being coherent enough to claim the non-governmental ways in which we organize families?
Thank you for your question. These are hard issues. And part of what we need to do in our field, in our world, is really change our language, so that, because we don't capture everything, even long-term care, which is now long-term services and supports, is so off-putting to people. And what does that actually mean? With Title VII, again, there's a new movement in family responsibility discrimination to think about having caregiver status as a protected class in addition to age, race, gender. There are some emerging areas in that regard. So.
Lynn, very nice job. We really
Thank you.
appreciate it. I have a question. You know, our committee is focused on those that are likely approaching death. And obviously the issue of caregiving is a much broader issue. The issue of long-term care is a much broader issue. And as you know, Medicaid is now turning out to be half or more long-term care for the poor, if you will. Are there any particular areas that you would want to reinforce that you think are of particular significance or particular import with regard to the scope of our work, which are those that are likely approaching death? Because many of these, I think, are good beyond that.
I will say that Medicaid for the old population is not just for the poor. And I'll give you an example. My aunt, my late husband's aunt, died last year at the age of 101. A very proud woman, middle class, who saved her whole life. She lived independently until she was 98, and then moved to assisted living and then a nursing home because of increasing chronic problems. She outlived her resources. This was a very proud woman who never, ever would have been expected to go on Medicaid. So Medicaid is really not just for the poor. It really is for the middle class if you have the benefit of living to old age. And we will see more of that in the future, and we need to grapple with that as well.
Thank you. Any more questions from committee members? Sure, Diane.
Thanks, Lynn. As usual, really wonderful presentation. My question is, how is the advocacy for the policy priorities that you articulated going to move forward? Is there a coalition for family caregivers? What do you see as the political process that is needed to actually get attention to these policy priorities on the Hill and in the executive branch?
Good question. This is an area that I have worked on with a number of you in the audience for more years than I care to admit. We used to think that as we all went through our personal caregiving experience, we would then finish that up and go march on Washington and change public policy. And as you know, that hasn't happened as yet. But I am optimistic. There is movement. And the fact that even here with your committee on end of life, you're also dealing with the family issues at several different fronts, I think we are seeing slowly and surely more of a focus and a recognition on family issues and to elevate that. And in part, I do believe it's because finally our elected officials are grappling with these issues on a very personal level. And usually it's the personal that drives us to act. So I do think, little by little, we are ratcheting up the need to move forward with the unit of care, if you will, as the person and his or her family, in a very broad sense, system.
Lynn, one last question. What do you see as the primary barrier or barriers to making progress in this area with regard to elected officials?
I'll say this is me speaking. I have to remember to do that. The primary barrier is that in our country, there are many who feel this is just what families do. This is just what women do. But again, as my slides show, when we look at the faces and the constellation of families before and now, we are also working and doing other things as well. It's not, we need to have public policy to better support families who do care and want to care for loved ones at the end of life. And it may be an expected role, but we also need to have better recognition and support.
Thank you so much, Lynn, for coming all the way from Washington, D.C. and being with us here today. So let's give her